Welcome to the Learning Lab. My name is Roman Garcia. What we're going to be talking today in this volume is the difference between a very complicated physical examination of the shoulder girdle and a simple physical evaluation of the shoulder girdle with the same result. Now, the reason I'm bringing up this issue is that as I've been scanning the public domain, I've been noticing that a lot of these educators, when they try to demonstrate the way to physically examine a body part, they're using quite complex type of movement patterns. And what struck me is that how unnecessary that truly is in order to grasp the information that is clinically relevant. So what I'm going to do now is I'm going to show you one of these very complex, superfluous physical examination that I just retrieved from YouTube. Now there are thousands of them littered throughout the YouTube infrastructure. I'm just going to show you one. I could have picked this one, I could have picked another one, but I'm going to show you one. This examination is for a physical evaluation called the Apley scratch test. Now I'm going to show it to you, and I'm going to be talking over it so I can point to these moments in the examination that go against the common sense of a physical examination. Now let me just show you here. Carlos, if you can zoom in over here, we're going to go and we're going to show you. Let me see if I can get the... Alrighty, here it is. I've got it already set up here. Now, this is a physical examination. This is the Apley scratch test. Now, for the life of me, I cannot begin to understand, for one thing, why they would want to put a patient through these motion patterns. Because most of them, with somebody that's suffering from a shoulder issues, most of these movements will be extremely painful. And the golden rule of medicine is always first do no harm. And you got to try to do a physical examination on an individual, on a patient, without having the patient suffer. So this particular sequence that you're going to see, in my opinion, for somebody who has a shoulder discomfort, will find it extremely difficult. It's quite literally is a very unrealistic test, but the YouTube educational domain is full of these examinations, and I'm going to show you a way of evaluating an individual without having the individual go through these unnecessary movements. But let's go through this video first. Now, I covered the identity of these individuals. This is the Apley scratch test. Now, if you can notice, look at the position of the hand of that model. I can assure you, anybody that has shoulder pain will not be able to assume this position. On top of that, having the patient assume that position, you're stressing the actual tissue that you're trying to evaluate, it, potentially creating more harm to that tissue. And the information you get from it is of no clinical relevance nor value. Let's see what he's doing. He has the patient bring the arm back. Now, this is another movement of the procedure. Now, you can see what he's trying to do. Now, I believe that this test is to determine the mobility of the shoulder and stressing a particular tendon in the shoulder, the rotator cuff tendon. What this examiner is trying to do is to see, to determine if this individual is suffering from an impingement syndrome, which is basically it's a condition where the rotator cuff tendon is getting squeezed between two bony surfaces. So this practitioner is specifically saying that this type of examination is appropriate for the more sports-oriented individuals. Now you can see these complex movements that this model is having to go through. Now, mind you, this is a physical examination that's being encouraged to be incurred on a patient to determine the range of motion of the shoulder. Now all these motions are putting tremendous stress on the rotator cuff tendon. Again, this is a typical physical examination that's in the public domain, that's trying to be taught to the individuals on how to evaluate a shoulder dysfunction. In a little while, I'm going to show you a very simple one where you extract the same and even more valuable information without having the patient go through these stresses, these physical stresses. He's trying to incur information. Now, I'm going to spare you, Carlos, you can come out. I'm going to spare you the rest of the video because it's putting this individual through these complex motion patterns, and then he's reciting over it on what information he's able to extract from the patient going through these motions or lack thereof. Now, what he's trying to examine here is a rotator cuff condition. Now, I'm going to briefly show you a little mock model that I created, so anybody that's seeing this video who doesn't have an anatomical understanding of what I'm talking about insofar as a rotator cuff tendon, I'm going to show you in a model what the rotator cuff tendon does in the shoulder and why it's so susceptible to injury. Whether you're an athlete or not, the rotator cuff tendon is one of those tissues in the shoulders that there's about a 90% chance that if your shoulder is starting to hurt you, it is the rotator cuff tendon. And I'm going to show you why that is so. Now, this is a model, mechanical model of what the shoulder joint would look like. This pen right here illustrates the humerus bone. The humerus bone, Carlos, if you can go to Anna over here. This pen demonstrates, is showing this bone right here, the humerus bone. Obviously, this is the shoulder joint right here. Okay, Carlos, you can come back to me. Now, this pen represents that bone. This area right over here represents the actual shoulder joint itself. This is the shoulder joint itself. This white structure right here, this elastic band right over here, that's the rotator cuff tendon. It basically overlaps and envelops the end of the humerus bone, the long bone of the upper arm. Now, what this tendon does simply, it's a complex tendon. It's made up of 4 different muscles. What this muscle and this tendon do is it maintains the head of that long bone centered on the joint. That's basically what it does. Now, throughout our lives, this tendon is under constant tension because its job in the shoulder is to center that bone. That's all it does. It centers the bone. Now, throughout life, this bone is trying to rise up onto the shoulder joint. The tendon centers that bone. So when these muscles are in constant, they have a constant tone. So throughout its life, there's always a traction on this tendon downward. Now imagine a structure that for 80 years, 90 years, 100 years is under a traction or is always being pulled down. It always develops tears in it. That's why this tendon right here, the rotator cuff tendon, is so susceptible to injury. Now to test it, Carlos, we can go back here. To test it, you don't need to place your patient through these complex movements patterns. I'm bringing you a picture of one of my patients who we treated recently. He was suffering from a rotator cuff issue. Now, he's laying on his right side. The picture is a little bit complex to decipher, but he's laying on his right side. So you're looking at the shoulder from the back. Now, I know you really can't appreciate it that well, but most folks, all folks who have a rotator cuff problems, you don't need to put the individuals really through any kind of physical maneuver to determine if they're suffering from a rotator cuff tendon. The rotator cuff muscles will give you a visual representation of whether they're under duress or not, and they do it by atrophying. Atrophy is very easy to see and observe in a patient. Now, this individual had substantial atrophy of the rotator cuff tendon. I know you cannot appreciate it in this picture, but right here is where the rotator cuff, one of the rotator cuff muscles is, the infraspinatus muscle. This muscle on this patient was atrophied. And what atrophy looks like, it looks like a scallop configuration on the back part of the shoulder girdle on an individual who's suffering from either a rotator cuff tendinitis or worse, a rotator cuff tendon. Now, Carlos, if you go back to this model right over here. Now, as we grow older, because of this downward tension on the rotator cuff tendon, this tendon starts to develop tears in it. It's inevitable. Everybody gets it. Some become symptomatic, some do not. It all depends on whether inflammation sets into the tendon or not. But as this tendon starts to develop tears, I don't know if you can appreciate this. As this tendon starts to develop tears, it loses that ability to center that bone. So it's not being exposed no longer to a downward tension. This bone will rise up onto the shoulder joint. I'm going to show you an x-ray of what that looks like. Now, one of the problems that we cause, you can come back to me. One of the problems that we have in the physical therapy, in the rehab domain, if you're not an MD, is that we don't get access to x-rays. A lot of physical therapists, a lot of manual practitioners really don't know how to interpret x-rays. Now, that's not the case for me. I see thousands of x-rays. I've seen thousands of x-rays in my career, and I see tens of them throughout a whole week period. I've got the opportunity to see many x-rays. Now, to examine a rotator cuff issue, you can literally diagnose it just simply on a simple x-rays. And I'm going to show you what a diagnostic x-ray of a rotator cuff issue looks like. But what I want to do now is that I want to show you what a simple shoulder evaluation would look like if you're trying to determine a rotator cuff pathology. Now, I've done this in the past, but it's been trying to diagnose different types of conditions. But this particular volume is going to be about how to evaluate a rotator cuff issue, something that the presenter on the video was trying to do by putting that patient through all those complex maneuvers. Now, my assistant Anna is going to help us with this. She's going to stand up. Now, the point of the Apley scratch test is to see if the shoulder is dysfunctional, if it's lacking any range of motion. Now, the reason that I find that somewhat ridiculous, that test, and especially incurring all that stress to the patient, is that there are really only two motions that are important when you're physically examining somebody to try to determine what's causing their pains in the shoulder. And that's abduction, and I'm going to show you what that is, and external rotation, especially external rotation. Internal rotation is not an important range of motion to try to determine if the individual is suffering from not. The key motion in the shoulder is rotation, as is in most joints in the body. Now, what you have your patient do simply is this. Anna, with your hands in this position, raise your arms overhead, bring it down, okay? Do it again, bring it down. Okay, this is abduction. Now, Anna's able to do it because she doesn't have any shoulder problems, but let's say that she was only able to come up with the left arm up to this position before she encountered pain. I wouldn't have her go any more than that. Now, what I try to do then is that I've established she has pain up to a certain limit of range. So I try to determine where is it coming from. The first thing I think of is rotator cuff, because as we saw, the rotator cuff tendon is always under a traction type of strain. That's what it's supposed to do. Now, what you want to rule out is that if there's any pathology inside the shoulder, you do that simply. You grab the arm. We've talked about this in other videos. You come up like this, you bring the arm up like this. She may experience pain doing this motion. You don't have to take it up to this area over here. You don't need to bring the arm up under duress for the patient to see if she has the motion. You don't need to do anything like that. we already know, we've already established it has pain going at a certain range. So what we do is we go up like that. The shoulder moves fine. We ruled out pathology inside. Now, the next thing you do is the most important range in the shoulder, or like I said, in any part of the human body, which is rotation. What you do is you bring and you establish the rotation itself. This is rotation. This is normal. This is what you want in an individual. Some folks have a little bit more, some folks have a little bit less. Now, usually if the individual has a rotator cuff problems, you would not be able to bring the shoulder out all the way out to a full external rotation. And again, you don't want to establish that because the patient is in pain. So you don't want to create any kind of physical examination maneuvers that's going to incur any kind of pain on the patient. You don't need to do that because I'm going to show you how the rotator cuff muscles tell the examiner that there's something wrong with here, and that is by atrophy. Since the rotator cuff muscle is always under a tone, whenever it gets into trouble, its tendon gets into trouble, it loses that traction effect, that stress that's incurred onto the muscles. So the rotator cuffs start to atrophy almost immediately after it's been in an inflammatory state for a period of time. Now, you observe that, and how you do it is very simple. You're going to turn around like this. You palpate. That's all you do. You palpate. Most of the times, you're going to see the atrophy. Just like I showed you the picture, most of the times, you're going to see the atrophy right here. You're going to see it right here. You'll see it. You're going to see it. This is the infraspinatus muscle of the rotator cuff. You're going to see the atrophy right here. It's going to be a scallop. It's going to scallop on you. Just like that picture showed. That gentleman obviously was more involved. He had had shoulder problems for years. But you'll see a scalloping right here. And even in an acute condition, you're still going to see some diminution of the tissue volume itself. You see it, you can touch it. You'll feel a scallop. You'll feel a scallop. This is how you examine it. You just palpate for it. You'll be able to feel it. It doesn't hurt the patient. You don't have to put the patient through complex movements such as this, which are very painful, even in a healthy shoulder. You don't do nothing like this. This is just incurring more stress on the shoulder. This is very amateur type of physical examination. The seasoned professional will be able literally to be able to observe a rotator cuff problems. Now, Anna, what you're going to do is you're going to lay on your side facing that way. Now, the reason I put Anna in this position is because this is the position of the picture. The picture was taken with the patient in this position, and even in this position with that patient, especially because it was so obvious, there was so much substantial atrophy that you can see the scallop right here. Now, I recommend that to try to observe the atrophy of the rotator cuff muscle, that you have the patient stand up with their back facing you. But again, you can position the patient in this position too. Again, patient comfort. You're not traumatizing the shoulder by trying to examine it, like that Apley scratch test that you saw by that presenter. Those ranges of motions are going to traumatize the structure that you're trying to evaluate. And the first rule of medicine is always first do no harm. But so Anna, you stay right here. Carlos, I'm going to show the folks out there now what a rotator cuff. Now, this is what, now for unfortunately, like I said before, most physical therapists, manual therapists don't have access to x-rays, nor to MRIs or any kind of diagnostic examination, at least the pictures. But this is what a rotator cuff shoulder would look like. This humeral head right here is raised up because this tendon, the rotator cuff tendon, runs right through here. It's torn, it's irritated. So the muscles lose their connection to those that vector traction force. So the shoulder automatically rises up. So if somebody were to bring you an x-ray of their shoulder, you can literally diagnose a rotator cuff problem pretty close to 90% sensitivity by just simply looking at the x-ray and observing for this humeral head. Now, this is, you can see how the humeral head is, again, is raised up a little bit. It's making contact with this bony structure. This is the acromion with the bony structure. Again, this individual has a rotator cuff issue. And you can see it, the humeral head is raised. There should be a black gap right over here. There's no black gap here because this bone has risen up because this rotator cuff tendon is either torn substantially or it's irritated, or it's been irritated for a long period of time. And again, this one is worse. You can see it's not only touching, it's overlapping the acromion. You can see the acromion superimposed on the humeral head right over here. Alrighty, so Carlos, we come back to me. So here we are. I just showed you a simple physical examination on how to try to diagnose a rotator cuff issue. It's done in about 5 minutes once you do it and once you know what to look for. The sign that you need to pick up, the most important sign, is the atrophy. If it's an acute injury of the rotator cuff, just a tendinitis, and it just happened a couple of days ago, a week ago, you're not going to get atrophy. You'll diagnose it through other maneuvers by ruling out more serious conditions. But again, you never put the patient through these complex maneuvers such as the Apley scratch test and the thousands of other rotator cuff examination tests that I've seen out there, of which all of them are potentially traumatizing to the individual. Now, if anybody sees this video and you have any comments about it, if you disagree with what I'm saying, please make your thoughts known to us. Text us, call me. There's always a phone number on the videos. For anybody that's seeing this video and wants to communicate with us, please, like I said, make your thoughts known to us. And thank you for watching, and until next time.